Yeah, I think on Thursday I had this patient, so just a few days ago. This is exactly how he presented. Um, so he came in, he was an elderly guy, like 65 years old. Actually, he was maybe 61. But anyways, he presented with complaint of headache, difficulty walking, nausea, and vomiting. Um, and when asked about why is it difficult to walk, he states because he can't seem to get his balance. So kind of describing almost like vertigo. But he denied weakness or pain. And he stated he had vomited 4 times that day, and he hadn't drank anything since last night. So he was pretty worried that he was dehydrated. That's actually what he was saying, what was wrong. He just said, I'm dehydrated. I just need some fluids, and I'll be on my way. His vitals were stable, other than a very mild tachycardia. I think his heart rate was like 102. Um, On exam, he was mildly confused, a little bit just slow to respond to questions. I had to ask the same questions more than once. But there was no focal deficits, no nystagmus. His eyes looked okay. He could do the finger to nose. And when he stood, he didn't fall, but he like did he said he would like prefer to sit down because he didn't feel uh, very sure in his feet. So I initially had a pretty broad differential diagnosis. I kind of thought maybe this was a vertigo chief complaint, and so I was thinking of peripheral or central causes of vertigo. So I was thinking about posterior stroke. He's a little bit on the older side. He said he had a history of hypertension, but he hadn't seen a doctor in a long time, so it wasn't very well controlled. So I was thinking maybe this is a posterior stroke, or something like benign paroxysmal positional vertigo or vestibular neuritis. For him, his difficulty walking and his balance, it was constant though. It never got better or worse. And so it didn't quite fit with the this benign paroxysmal positional vertigo. So it felt more like a posterior stroke. I was also thinking about electrolyte abnormalities, because was this a strange presentation of DKA that could cause nausea, vomiting, confusion, and if you're dehydrated, you could get a headache. So that kind of thought that fit. I was thinking about hyponatremia or high or low potassium, just kind of various electrolyte derangements. And then I was also thinking about infection. I think infection could cause a headache. It could definitely cause nausea, vomiting if you had meningitis. And he was acting confused. So I thought, does this guy have an encephalitis or meningitis? And then medication toxicity was kind of like in the back of my mind. Like if everything looks normal, maybe he's on some new medication or supplement that's causing him not to feel well. But anyways, my workup, I just got basic labs with some extra electrolytes, given that he was having the vomiting and kind of strange presentation. And then I didn't have an MRI where I was at, and so I got a CTA of the head and neck, is what I ended up going with. And these were the results. So the sodium came back at 106, very, very low. The normal for our labs, I'm not sure if you have the same ones in Vietnam, but the normal for us is above 135. And below 120 is considered like a severe range sodium. And his sodium was 106. His potassium was 2.7. But otherwise, everything was pretty normal. His creatinine was normal. White blood cell count was normal, normal lactate. So I wasn't concerned about infection anymore. And I did send a urine. I didn't put that here, but his urine was normal. And then his imaging was completely normal. Although looking back, he probably didn't need imaging. I think as soon as we saw the sodium of 106, that pretty much explained all of his symptoms. But he had actually already gone over the CT scanner by the time I saw his sodium. Um, so then I asked myself, like, this is maybe the lowest sodium I've ever seen. He seems like he's having pretty severe symptoms. So I looked back up and double checked, how do I treat this and how do I do it safely? So some basics are, sometimes you'll have patients who have hyponatremia and they have symptoms, but it's possible the symptoms aren't from the hyponatremia. So the first thing you have to do is this patient symptomatic, and is it actually symptoms from hyponatremia? You're going to take care of patients who have cirrhosis or liver failure. and they may chronically have low sodium. They may live their whole life at a sodium of 120, but they come in and they're having nausea and vomiting, and it's not from the sodium. It's actually because they have spontaneous bacterial peritonitis, or they have some other infection. So you have to make sure that you think this is truly from the sodium, because a lot of people live with low sodiums and they're not symptomatic. One thing to note is usually patients are actually asymptomatic until sodium levels drop below 120, but it could be higher if the change happened rapidly. So that's another thing to think about, is try to get a sense of when was the last time this patient had labs, and was there anything that happened between then and now that could have made this drop suddenly, or do I think this is more of a chronic change? And if it's chronic, it really needs to be below 120 before they get symptoms. If it was an acute change, then maybe they'll have symptoms around 125, but the symptoms would probably be kind of on the mild side. So let's say you've decided that they are symptomatic and this is an acute change in sodium. Now you have to break up the symptoms into 3 categories. So you have not severe symptoms, which are considered gait disturbances, which he had. He had trouble walking, falls, and trouble with concentration, which he definitely had, I would say, all of these. And then moderately severe would be nausea, confusion, or headache. And he had all of those as well. And then lastly, severe. So it'd be nausea plus vomiting. And he did. He said he'd vomited 4 times that day. Thankfully, he did not have a seizure. And although he was confused, I would say he was still probably a GCS 14. So still okay there. And his cardiorespiratory system was totally normal. So no dangers there. Okay. So regardless of which category you decided, you're going to do something about the sodium. It's just how aggressive are you going to be? And so another thing to think about before we get into the specifics of treatment is this is one of the few diseases that we must treat slowly. You can get into some serious trouble if you treat it too fast. And that's because sodium makes up such a huge portion of our plasma that any changes in the sodium can cause sudden shifts into or out of the cells and into and out of the plasma from the like your tissue. So if you treat it too fast, the sodium rises and now the fluid shunts out of brain tissue, which is the most dangerous thing. And if that happens really fast, you get this thing that we call osmotic demyelination syndrome, which is basically almost stroke-like symptoms. They usually get dysphagia, confusion, dysarthria. So, and these are often irreversible. No matter what we do, we can't fix this problem. So once these neurons are demyelinated, that can sometimes be permanent. And the other thing is that these symptoms don't occur until 2 days after the rapid correction. So if we correct it rapidly in the ER, we might pat ourselves on the back and think everything's okay because the patient's symptoms have improved. But then 2 days later, while they're up on the medicine ward on the floor, they all of a sudden develop all these symptoms. And it's actually because of what we did 2 days prior in the emergency department. So treatment continued. So I think step 1 is deciding, is this patient hypovolemic or dehydrated? So if the patients come in and you think that the reason their sodium is low is because they're dehydrated, you're going to want to give fluids first, just like you would any other patient. So you can give them, we would recommend normal saline as opposed to lactated ringers, just because normal saline has more sodium in it. So this would be definitely one of the times where your choice of fluids is important. So remember to choose normal saline. Or if you think that the patient, because they're hyponatremic, have vomited so much that they're now become dehydrated, in that situation as well, you would still want to give normal saline first and make them euvolemic. So rehydrate them, resuscitate them. So look for signs like dry mucous membranes, tachycardia, hypotension, poor perfusion. If they're having any of those signs, give them normal saline first, and then you'll move on to the next step. So if you think that you've now got them resuscitated with normal saline, now you can start with our hypertonic saline. So we recommend 150 milligrams of 3% hypertonic solution, and to give that over about 20 minutes. If your patient had any of those severe symptoms, Then you're going to want to recheck the sodium as soon as that solution has finished, so about 20 minutes. And then you're going to want to give a repeat boluses of these hypertonic solutions until the sodium is 5 millimoles higher than it was when the patient came in. And so that may take 2 boluses, it might take 3, or it might take 4, depending on their fluid status. But you'll just keep repeating this cycle of giving them a bolus, checking sodium, giving them a bolus, checking sodium, until they've gone. So in my patient, until he's gone from 106 to 111. Once you've gotten to 111, their symptoms should improve quite a bit, which is what happened in my patient. He was more alert and oriented, and he didn't vomit at all in our emergency department. And his nausea improved quite significantly. And at that point, our job in the emergency room is really done. We've kind of, for the severe patients. In the non-severe patients, so whether it's moderate or non-severe, it doesn't really matter. You're just going to give 1 bolus and recheck. And in this case, you want to increase the sodium only 5 millimoles over 24 hours. So it's just the timing is the difference. So in severe, you want to get it to go up 5 really as soon as you can, because those severe symptoms are, like we said, they're severe. So there's actually potentially brain damage going on because of the fluid shifts in the brain. But in the non-severe, you just want to do 5 mils over 24 hours. So in the emergency department, that would usually just be 1 bolus of hypertonic, and then the floor or the ICU can do the rest. If you don't have hypertonic saline, you can give 2 ampules of crash cart bicarb. So that actually ends up to be about 200 milligrams of the 3%. So it's slightly more than this bolus, but it's pretty darn close. So you don't have to have hypertonic saline, or if it's like, oh, we have to get that from central pharmacy, it's going to take 30 minutes. You could just give the ampules of bicarb. It's really just the same. And you could even put it in 150 mils of saline, and then you created your own hypertonic solution. That's pretty easy to do. Your nurses could easily make that happen. You can just inject it into the saline bag. So that's really all I had for hyponatremia. Here's the big things to remember is that hyponatremia can cause vague symptoms, including difficulty with concentration, poor balance, nausea, vomiting, headache, seizures, or coma. Your first step is to decide if the patient is hypovolemic, and if so, start with the normal saline bolus, and then subsequently treat with 150 ml, 3% hypertonic saline, and then reassess symptoms and serum sodium before giving more. And remember that what we do in the emergency department, we might not realize we made a mistake until 2 days later. So we have to be very careful and not going too fast. And then remember, if you don't have hypertonic saline, no big deal. Everyone has bicarb, and you can just give 2 amps of bicarb. And then all of these patients are definitely being admitted. Most institutions have a pretty hard cutoffs, but a lot of these patients are going to need to go to the ICU because they need those sodiums rechecked so frequently. If they're in the severe range sodium, they're going to need to get rechecked sodium like every 20, 30 minutes. And that's not something the floor can usually handle safely. Any questions about hyponatremia?
Several department I know don't have the hypertonic saline 3%. Sometimes they have the 10%.
Okay. Yeah, as long as you
How you management with the 10%? You dilute or you can give a 10%.
yeah, I think you could still give the 10%. You just need to do the calculation and figure out how much to give. So it's about 3 times more concentrated than this 3%. So you're gonna want to give about 3 times less. So I would imagine it's pretty simple. But you could just probably give 50 mLs. But I would talk to your pharmacist or double check that. But the concentration is okay, and that's why it's okay to give the amps of bicarb as well. You just have
For
to
me, I usually dilute. So I calculate 150 with the 3%, and I calculate the sodium, and then I dilute 10%. It's the same sodium.
Okay, yeah, that I think that's still safe. Yeah, it depends what kind of saline you have. I've
I think it
also heard
works.
some institution have a 23% saline, and so they just have to give less.
Yeah, I think you either give less or you just dilute. But I guess the important part is to recheck your sodium and make sure you're not correcting it too fast. So yeah, either way works. I think whatever the institution is or you are more comfortable with, right? At the end of the day.
Yeah.
Maybe sometime it urgent, we no need to dilute. We just give less volume of the 10 or 10%, and then we check the sodium, right?
Yeah, yeah, I think that's fine. One thing is if you're giving the higher saline, if it was to extravasate, so if the IV was to blow, that could be harmful to the soft tissue. So that would be a benefit to diluting it. But sometimes, I know the institution that I worked at that did use the 23%, we had to put in central lines. We weren't allowed to do it through the IV because if the IV blew, it was really dangerous to the soft tissue. So we had to put in a central line.
Okay.
Awesome. Well, the last question we had today is, I mean, I thank you everyone for being so flexible about the change in time and canceling and not canceling the last minute. But how do we make these sessions better for you? You know, because we do want people to come every week and we want to make it easier for everyone to come every week, but also easier for people to learn. Do you have any feedback on this so that we can help change it for you? Are they too simple? Is it too easy? Do you need more time before each week with the presentations? What is it that is going to make the learning better for everyone? Because we like teaching, but we also want it to do it the way that works for everyone that's learning. It's okay as is, or more case, less case, more questions, less questions?
Here's
I
a
think
bunch of questions.
I think every week is okay, but after you teaching, can you share us with the PowerPoint? Because sometimes when we have the more time to read again your teaching, maybe we have the more questions.
Okay. Do you feel like one time a week is okay and the time is okay, or should we change the time?
I not
we
need to change the time, I think.
It's okay. Okay. Do you
Maybe
feel
more,
like there's
maybe you can agree the more case from the Vietnamese attendant, because when we set up our case, maybe we can method your more your experience.
Okay. Thank you. Dai, do you have any thoughts? You've been through so many years, Dr. Dai, of this. How do we make it better or make it easier for people to come? It was just this week. Scott has work today. Scott has work today, and I'm in 2 a.m. Mm.
Okay, perfect. Good to hear. Okay.
Okay.
Thanks,
Well, thank
everybody.
you all. See you next week. Normal time. Normal time.
Yep. Yeah, that's next 3 weeks, normal time.
Yeah. Okay. Yeah. Okay. Okay. All right. Okay.
See you,
See
everybody.
you, everyone. Bye.